They may place drains, but they've already done surgery, they know what the anatomy is, so they're a little bit different. But for any of us, if we're in the ED or doing even like a scalp washout and there's no actual bone fracture, we're not going to leave a drain. Okay. Remember the scalp acronym. Okay. You have skin, you have connective tissue, then you have the aponeurosa, which is the galea, then you have the loose areolar tissue, and then the pericranial tissue, and then the bone. Okay. When we go through, like, we need to know these layers, because if the patient, comes in and has a laceration all the way through the galea, most of the time we take those to the OR for a washout. Okay. Versus if we can tell that the galea or the aponeurosa is intact, then we can just wash that out at bedside and close without having to take them to the OR for a real good washout. All right, skull fractures, if it's open or depressed, okay, or depressed, we need surgery. If it's slightly depressed, really up to neurosurgery, depending on what they want, whether or not they'll go in and fix it. And then just a simple or linear fracture normally does not require any surgery. Okay. Remember that the temporal bone, right, is super fragile. The sphenoid bone. Okay. What's behind the temporal bone? What blood vessel? I think I heard it. Middle meningeal artery, right? So if someone gets hit in the side of the head, right, if we suspect a temporal bone injury, like they have the battle signs, they have raccoon eyes, or a lot of swelling or bruising over the temporal region, we absolutely want to do CT, because that bone is very thin and can fracture very, very quickly and can cause a bleed because of that blood vessel directly behind it. All right, basilar skull fractures are really, really significant. Okay, it basically means that there's a fracture that is so like you remember your cranium, right? It does have parema, it does have ways of blood vessels spitting out, but normally you have the inside of the skull is has the dura, and it's all kind of contained. Right? When you have a basilar skull fracture, that's no longer contained. So you see like CSF dripping from the ears or the nose, and if you put like a gauze underneath that, underneath the ear or the nose, it actually, the CSF will make a halo, okay, around the bleeding. Okay, does everybody see that discoloration on the bed sheet? Okay, that's CSF next to blood coming from that ear. We can see a lot of hemotympanum, okay, because there's blood collecting in the inner ear. Most of the time, depending on how bad it is, we can, if it's very mild and doesn't have any CSF leaks, then we can manage this conservatively, but most of the times maxillofacial or a combination of maxillofacial with neurosurgery will go in and try to fix whatever they need to. Okay? Complications that we see with basilar skull fractures, okay? Vascular, we can see a lot of dural hematomas, we can see CNS deficient cranial nerves 3, 4, and 5. Deficits, okay, or like I said, CSF leak. When we see that CSF leak, we start them on antibiotics because there's a major concern for meningitis. All right. So on imaging for skull fractures, we do X-ray kids and babies, but not so much for adults. For adults, we're really going to go and do CT head, like non-contrast. Okay? We can do CT heads in kids, but we try to limit the amount of contrast that we use in them as much as possible. All right. Can anybody see the fracture in this kiddo?
Top.
What's this top part? Is that a fracture?
Open.
No, that's the front. No.
With the
See
posterior?
it?
Like little
Yeah.
posterior?
Right there. You can't really see it on the lateral side, right? But on the AT side, you can see it on that right side temporal bone. Right. Now again, when you have CTs or sometimes when you have, really good x-rays, you can see linear fractures off of the sutures, okay? Sometimes, but what do you think this one is? This problem. Someone did surgery on this patient, right? This is from a craniotomy. Okay, they put the skull plate back onto what they opened up to relieve for pressure. Okay. All right. Now, when you look at CTs, there are different windows or ways that we call them windows, but they're just different imaging levels on what we can actually see. So you can see on, like, when we put them on the blood window, we can see brain matter, we can see blood, okay, but the bony structures are not that really crisp, but when we put it on the bone window, you can actually see where that fracture is from this injury. Okay, normally when we look at skulls and CTs, our body likes to have that symmetry, and I've said this before, is if you have something on one side and it's not on the other, most likely it's damaged on that one side. Okay. Alright. Now when we talk about traumatic brain injuries, there's a couple things that you need to know. We already talked about the Glasgow coma scale. Normally if it's like a mild TBI, you have an initial GCS score of like 13 to 15. Okay, if it's a moderate, it's 9 to 12, and then if it's severe, it's less than 8. Right? Knowing how much, if you ever work in like a TBI clinic or work in a trauma clinic, and you're even you're seeing these guys follow up in your primary care clinic, knowing how long they actually lost consciousness for is really important, because it'll kind of suggest how bad their TBI was, if they had any amnesia type of effect from it, and how long that was, okay, and how long they were altered. Really depends on, or really kind of determines how bad the traumatic brain injury was. Okay, looking at and remembering where the fox cerebri is and where the the septum is. When we start to look at like CTs of the head, and we have a slide coming up, that if you kind of know where these are, you can kind of help dictate, if you have mass effect or you have herniation or all this stuff. Okay. Again, this is just something that you should already know. If not, you'll be taught, or you'll be tested on it, at least in here, and then as well as in EM. Okay, going through those different types of GCS levels, and whether or not you should do a CT, or like what the next step is. Okay. All right, primary brain injuries. These are the initial injury. Okay, not much we can do in order to treat the initial injury, but what we try to prevent is the secondary injuries. Okay, the secondary brain injuries. That is where, if we can keep them oxygenated, we can keep them ventilated, we can keep their blood pressure under control, and not hypotensive. There's, certain things that we can do in order to really help prevent these secondary brain injuries. We can't, once ischemia already happens from that primary brain injury, there's no way to prevent it from happening, or prevent that initial insult. We try to prevent it from getting worse. Right? We can't prevent that hematoma from forming initially. Right? You get struck in the head. I can't not have that kid be struck in the head again. Or not again, but you get the point, right? We can't prevent those primary injuries as much as possible. We can try to wear helmets, but we can't prevent the primaries. So we want to try to prevent the secondary brain injuries. So how do we do that? We prevent hypoxia, prevent hypotension. We want to have an increased, or we want to have a normal ICP, or intracranial pressure. Okay, we can try to prevent an increase of that. We really want them to be normal glycemic. Okay, we don't want them to be out of range, as well as we can prevent seizures, which is why a lot of times we will give a prophylactic seizure medication, right, to help prevent that. Okay, so this starts in circulation. Why? Okay, and we'll get to that in just a minute. For airway, Okay, we know that hypoxia can cause worsening of the secondary brain injury. So, you know, this is nothing really new. It's keeping that C-spine neutral, not you're intubating when we need to, and having a low threshold for intubation, and you know, really trying to prevent you know, hypoxemia, hypercarbia, and then you know, trying to if they aren't spontaneously ventilating, intubating them again with a very low threshold. Okay? I don't think any of that is really new. Okay, again, hypoxia and hypotension. These are the worst two things that we can do to people who already have a TBI. Okay, you already have that primary insult. If we can keep them from being hypoxic or hypertensive, it really will help mitigate their follow-on effects. Okay, some things that we try to avoid, right? We can't really help during transport, but we can teach EMS to not let the oxygen desaturation get below 60. Okay, what's a normal oxygen saturation?
90.
About 90, right? Round about, you know, some say 92, some say 89, but 90 is a good cutoff, right? We want to keep that about 90. If we don't, right, it actually increases their mortality by 3.5 increase, fold increase, okay? So teaching that, you know, those medics, hey, like, put the pulse ox on, maybe put the CO2 monitor on, so you can really, you know, monitor that. And you guys know the signs of hypoxia, right? Impaired judgment, confusion, being altered, being in coma, having, you know, cold, pale fingers, toes, tachycardia, tachypnea. Okay, those are the things we look for signs of hypoxia. And breathing, okay, pulse ox. Again, this is nothing new. What can give a false reading? Carbon monoxide poisoning, fingernail tail polish. Okay, cold, yeah, right? If you don't have good peripheral perfusion, you're not going to have a correct pulse ox. Good. All right, so now we get into CCP, cerebral perfusion pressure. Okay, we want to keep the CCP or CPP between 60 and 70 millimeters of mercury. Okay, this is dependent on our MAP and our ICP. Now, MAP, remember, is your systolic over your 2 times the diastolic divided by 3. Okay? So our normal MAP is between 80 and 90. And our normal ICP is between 10 and 15. Okay? We can only really measure ICP directly, right? With a Bolt or an EVD, which is a endoventricular device. Okay, it can drain, but it normally measures. It's actually placed within the ventricles of the brain, through the scalp, or through the skull. Okay. But if we can keep these between 10 and 15 and 90 or 80 and 90, then the CPP, will be between 60 and 70. Now, cerebral perfusion pressure is, it really, you know, is one of those really hard things to try to manage sometimes. Because the patient is hypotensive, or, you know, they're really in shock and we can't get their blood pressure up. There's other things that we can do in order to try to increase the MAP. Okay. But if either the MAP or the ICP, if the MAP decreases or the ICP increases, then the CCP actually decreases. Okay. So we really want to try to manage both of those to prevent or to keep the brain perfused. Okay. All right. So how do we get the ICP? Okay. This is the volume of the intracranium. Okay, equals the volume of the brain plus the volume of the CSF and the volume of blood. Okay. So we can manage CSF with those intraventricular catheters, like I talked about, the EVDs. Okay, we can manage the blood volumes with, you know, just fluids and respirations. Okay, we can relieve the pressure with surgery, but we can't remove brain volume. Right, in most cases, we can't remove the brain. We don't really want to, okay? So we let the brain swell. If we need the brain to swell, then we do surgery in order to remove that part of the skull cap in order to let that brain swell, okay? Especially when we can't do, if all of the other measures are not really keeping up with the swelling, right? There's only so much we can do. We have to allow for that brain to swell. So, you have the intracranial pressure, right? We have the intracranial brain, CSF, and blood, and now we have the systolic pressure, right? There's only so much we can do with inside the cranium. So what can we do with the systolic blood pressure in order to try to keep the cerebral perfusion pressure normal? Okay, so we try to maintain the systolics between 90 and 110. Okay, this is really, really hard to do sometimes when we have patients who are really hypertensive, okay? Or say you're on the opposite side and they are having a stroke, okay, but it's a hypertensive stroke, and trying to get their blood pressure down is also equally just as hard sometimes, okay? So, what is the map? Remember 1/3, or you have the systolic plus 2 diastolics, divided by 3, okay? That's a little bit of math. I just want you guys to really understand the relationship between the cerebral perfusion pressure, the MAP, and the ICP, okay? If all else fails, right, you forget this whole calculation, right? You're not neurosurgeons. Hopefully you're not taking care of neuro ICU patients or even, ICU level patients, first off the gate. As long as you can keep their systolics, aim their systolics around 110, normally you can at least initially manage their TBI, okay? Because around 110, right, as long as their ICP isn't going crazy, that's normally a decent amount when you have them, a little bit of swelling, because that keeps the ICP down. Does that kind of make sense? A little bit, right? It's really hard to conceptualize a little bit, and these are not easy things to remember. But just remember the MAP plus the ICP. So if you have a blood pressure of like 110, okay, and your ICP is kind of between 10 and 15, you should be okay. Okay. Normally we don't want the ICP above 20. Okay. If it's above 20, we have to do something like an EVD, or even a bolt really won't work. We have to get some way of decreasing the volume that's inside the skull. It's either going to be taking the skull cap off or putting in an EVD so we can drain off some of the CSF. Okay. So there are things that we can do, but not a lot of things we can do as primary care providers, or as well as, even at the World Twos. Okay, so with a bolt, okay, I've said this a couple times, it's an ICP monitor. Okay, it's placed by neurosurgery. It's a direct measurement of the ICP. It can either be placed depending on where we need it. Okay, we can either place it within the epidural space, the subdural space. We can actually put it inside the brain parenchyma and measure the ICP from the brain parenchyma standpoint, as well as through the intraventricular or into the ventricles of the brain. Okay. We do this for people who are salvageable. Okay, that's kind of sometimes hard to fathom, or to try to really comprehend. Like we're not going to do this for someone who's not going to be salvageable. Okay. So if they have GCS of between 3 and 8, okay, and an abnormal head scan, okay, but it's something that we think that they could potentially get over, right? If they got a direct GSW to the head and they have half their skull missing, that's not salvageable, right? Or if they have a huge hemorrhagic stroke and half of their brain is no longer functioning, it's just dead, it's not salvageable, okay? So it really you know, we need those GCSs and we need that abnormal CT scan, but we need them to be salvageable for us to make this worthwhile. Okay, so the EVD, another word for that is ventriculostomy. Okay, you can see it goes through the skull and it's actually a direct drain into the ventricles. Okay, and then you have the subdural bolt or the interparenchymal cameo. So that last little bullet, you know, it is possible to have an increase in volume of cerebral spinal fluid, blood volume, or brain mass, and still have a normal intracranial pressure. Okay, but that also means you have to have a decrease in your MAP. All right. So, which of the following changes of the components of the cranium best explain the pathology of intracranial pressure? What do you think? Who wants A? Who wants B? C? D? E? Who's this one? Okay, yes, A. Right? We want the increased volume within the cranium. Okay. Disability, okay. We're going to move on to GCS. I'm guessing this is not your first time seeing this. Okay, that's a normal breakdown. But when you have anything less than 15, okay, you have to break it down into eyes, verbal, motor. Okay, so knowing this scale is super important, and I will automatically guarantee you that it's going to be a question on the test to be able to grade a GCS score. Okay, this is something that you must know for at least being a military PA. Okay, extremely important. So again, the biggest thing when you want to talk about disability, it's say they have you know, disabilities in half of their body, but they're still able to give you a thumbs up. They're able to, you know, follow commands and move spontaneously on half of their body, or at least with one extremity. Their motor is a 6. Okay, their weight. It doesn't take into account that half their body is not necessarily doing what you want it to do. Okay. All right. Pupillary response. So we're looking for symmetry, reaction to light. Okay. We're wanting size. Normally it's between 3 and 4. You know, for adults. If it's pinpoint, what should you suspect? Narcotics, opioids. Okay. Okay. But in trauma, what we're looking for is that asymmetry. Okay. If one side reacts normal and the other side is what we call blown or super big, greater than 4, okay, it'll be normally like 6 to 8. And it'll be a non-reactive. Okay, you shine a light in it and it won't react at all. We call that fixed and dilated. Okay. You have to kind of remember. Oh, this is not an updated slide deck. Uh-oh, this is what I saved. On your slides. Oh no. All right, we'll go through it. I don't think I added too much. So hyphemas. Right? They're a collection of blood within the anterior chamber. Okay? Don't confuse those with subconjunctival hemorrhages. Okay? There's no blood within the anterior chamber on this one. It's the sclera or the conjunctiva that on the right side picture, that's what that is, a subconjunctival hemorrhage. Okay? You can see the difference with, you know, this one is just injected. Okay? We call that sclera injected with a hyphema, okay, injected with hyphema versus a subconjunctival hemorrhage, okay. You get hyphemas from like a blow to the face. Subconjunctival hemorrhages, although you can get it from a blow to the face, it's more common with like forceful vomiting, coughing, retching, you know, like a lot of like that increased intracranial or increased like intra-abdominal pressure, okay. Can't really get that from with a hyphema. Okay, hyphema is really truly a traumatic injury. Okay. Disability. Again, in terms of like normal pupils or abnormal pupils, what other things cause it? Okay, when you have the pinpoint pupils, remember you have the narcotics, the opioids, the organophosphates, but everything else, hypoxia, hypothermia, hypotension, orbital trauma, say it's like, you know, damage to the, I think it's the oculocranial nerve 3. If it damages the ability to dilate, okay, you may have that. You may have atropine. We can actually give atropine intraocularly to help dilate the eyes. Okay. If they're on cocaine or amphetamines, they may have abnormal pupils. They may just have an abnormal pupil, you know, to begin with. If you actually look at my eyes, my pupils are 2 different sizes. It's crazy. You look at my eyes later. But like, so you have to ask them if they're awake and if they can tell you, like, yeah, I've had this issue before, or this is nothing new, or yep, that's, you know, that's how my eye is. It doesn't react anymore. You may need to ask that patient just to say, like, what is the history? Okay. All right. For head trauma, there really isn't much difference in terms of what labs we want to do. Okay. The only one that is really different is if we think of like toxicology, right? If they are potentially, they've been exposed to organophosphates, or if we're already going to do, you know, the urine tox, urine alcohol, blood, you know, all of the normal toxicology screenings, but we suspect like a true organophosphate or, you know, a different type of toxicology type agent, we may need to run specific labs to try to, you know, rule those out or in. And then the other one is blood and CSF cultures. Okay, if we suspect any infection, okay, meningitis, we need to do that lumbar puncture and do the CSF studies. Not very common in initial traumas. Okay, that's more so in the neurosurgery realm, or with follow-up, or you know, neuro ICU, that kind of thing. Not maybe in like the ER, but not necessarily trauma. All right. What are we going to do in order to screen these guys? Like, what imaging are we going to do? We have to do emergent CT of the head without contrast. Okay. We may need to add on like what we call a CTV or CTA. Those are specific images. You know, a CT venogram if we suspect that the venous structures in the head are abnormal. I haven't done it too much. It's normally when we suspect like a type of stroke. And then CTAs, again, when we're trying to rule out other hemorrhagic causes, okay, like aneurysms or that kind of stuff, okay, or like subarachnoid hemorrhages. Although you can see subarachnoid hemorrhages on normals, non-countries. Okay. We can do MRIs. We've done MRIs on heads a lot, depending on if we are suspecting a type of stroke. Okay, so if the CT doesn't show any signs of a hemorrhagic stroke, normally we need to do an MRI again to figure out if there's been a ischemic stroke. Okay. And then the other imaging that we do is an EEG, okay, electroencephalogram. These are done by neurologists. These are if you think of like neurosurgery being the surgeon of the head and spine, neurology is the medical of the nervous system, medical doctors of the nervous system. Okay, so they're the ones who are doing the EEGs. We can do anywhere from random to 1 hour to a whole day. You think of the picture of all of the leads over the head. They're under camera. Trying to see if they're in what type of wave pattern their brain is actually in at the moment. All right, going through the CTs, again, CT head with non-con. There's different things that we can see. Okay, when you look at them, again, we have to look at these very, very quickly, but we're looking for symmetry, we're looking for skull fractures, mass effects, you know, soft tissue densities, air outside the sinuses, or what would be called a pneumocephalus. A natural neurosurgeon taught me this acronym. Blood can be very bad. Okay, so when you're looking at a head CT, trying to figure out what the neurosurgeon would want to know, okay, the first thing you look at, is for blood. You want to know where the hemorrhage is. Okay, there's 5 different types of hemorrhages that we see. Subarachnoid, epidural, subdural, interparenchymal hemorrhages, and interventricular hemorrhages. We already went over all those. Okay. Okay, so we look at the brain. Look for those bleeds. Next, we want to look at the cisterns. Okay. You can see on this middle picture up here. Okay, they have this the pons or the midbrain, and you have a little bit of black around it. Okay, that's the cistern. When it's completely effaced or closed, you won't see any of that black. You won't see the CSF around that midbrain. Okay? We want those cisterns to be opened. Okay? So cistern here is more, most of the time it's more pronounced than this. But if it's completely closed, you won't see any of those black. What that means is that there is massive swelling that's going on in the head, and herniation is possible. Okay? The next thing we want to look is the actual brain itself. We want to look, can we see the differentiation between gray and white matter? Okay? You can see the difference between gray and white matter. It's different shades of gray on all of these CTs. Okay? And then with that brain, is there a midline shift? Okay, there's a slide coming up. You'll actually see an example of a midline shift. Okay? You want to see that Fox cerebri, okay, that but anyway, you can see that Fox cerebri going through, right? We want that in the middle. So when that person is going through the CT scanner, we try to line that up in the middle, because if it's off, sometimes it makes us, or makes it a little bit difficult figuring out if there's actually midline shift or not. Right. Next, we go down to ventricles. Okay, we go and look for those ventricles. Are they open? Are they completely shut? Is only one shut? Is the whole brain, you know, having a mass effect and it's compressing them, or they're way off midline? You know, are they symmetric, non-symmetric? And then lastly, we look at the bones, looking for the fractures around the skull, looking at, you know, if we think there's a lot of face, we'll do a maxillofacial CT and see if there's sinus fractures or other facial fractures that could be contributing to this. Okay, so cerebral edema. Again, when we're looking at that brain, looking at that gray-white differentiation. Okay, on the image on the left, you can see there's a lot of different shades of gray and white in there, versus the one on the right. It's kind of all one contiguous type of grayness, right? You can't really see those sockeye and gyri and that differentiation between gray-white. Okay, so the one on the right is abnormal. Okay, midline shift. Okay, you can see that because of that massive epidural, okay, everything is kind of shifting over to the right. Technically on this is shifting over to the left. Because when you look at CTs, that's the left side. Right side, left side. Okay, so everything's shifting over to the left. Okay, but you can still see, right, the Fox cerebri, and everything in between is kind of just over. Right, you have that loss of ventricles on the right side. Okay, the ventricle, and then the middle ventricles here is not symmetric. So we treat this with elevating the head of the bed, and that's not necessarily breaking the bed. It's just having the bed flat, but with the head up. Okay. Occasionally, okay, we'll talk about, you know, hyperventilation later on, like a little bit at the end of the presentation. But we want to really maintain ventilation, okay? And that is, hypercarbia has been shown to do vasodilation, which then actually makes cerebral edema worse, which then actually increases your ICP. That's bad, okay? So we don't want to have any sort of hyperventilation and hypercarbia for long. And another thing you'll see is ipsilateral herniation, okay? So the pupillary change on the same side. So on this person, their left eye, their left pupil would be blown, okay? The same side as the injury. Okay. Now, correlating again with that, cerebral herniation and the anatomy, okay? Depending on where you have those types of hernias, okay, you have tonsillar or downward cerebellar through the foramen magnum. You have the uncal herniation, which is the cerebellum actually going over the tentorium cerebelli. Okay, those are your two most common herniations. And from this, right, you're going to have that blown pupil on the right. Your injury's on the right. Whatever pupil is blown, that's the side the injury's on. Okay. This is just review. Okay, remember subdural crosses the suture planes, so it's going to be more crescent. If it's epidural, it doesn't cross those suture planes, so it's going to be more football or concave. Intercerebral, okay, you have interventricular or interparenchymal. Okay. Again, subdural, those are the rupture of the veins. We see this more with elderly. And then with epidurals, remember they have that lucid period. Okay, they get hit, they're fine. They may have been a little bit stunned, or they may have lost consciousness for 30 seconds, but then they're fine. Okay, up until a point when this bleeding, this hemorrhage has gotten so bad that then they just fucking crash. They crash hard and they die. Okay, a lot of times we see with epidurals, we see the middle meningeal artery. Okay, so if you have any kiddo or any person who's got hit in the head on that side, you do a CT scan. Okay, you do not want them to be in that lucid period to send them home and to later die. All right, diffuse axonal injuries, AXI, these are rapid acceleration, deceleration injuries. Okay, you have the coup, counter coups. What that means is they got hit in the head and their brain kind of bounces around their skull, so it's a tearing of those vessels, okay, or not vessels, axons, okay. The brain just itself kind of has this internal assault, right? It can be caused by twisting or rotational forces. A lot of times we see it with child abuse and the shaken baby syndrome, okay? A lot of times the CT will appear normal, right? There is no hematoma. It's the axons of the actual brain itself. The brain parenchyma is those stuff that's damaged. It's not necessarily bruised. It's not bleeding. It's not hemorrhaging. It's just that it is enough of a tearing force that they don't wake up. Or they're very, very altered. It's very hard to catch DAIs. Okay? All right. Couple more minutes. So elevated ICPs, how do we manage it? So general guidelines. If you remember everything on this screen, normally you should be okay. I tried to make it at least one slide where everything's there. Okay? So you want to try to control the blood pressure between 90 and 110. Try to position that head of the bed. Okay, it says greater than 30, but no more than like 45. Really, 30 is good. Okay. If we need to remove that CSF, we're going to do a PVD. We do not really recommend hyperventilation, okay, because it actually has shown to increase ICP. Again, I will go over the one specific case in which we may want to try it, being military members, but otherwise we just don't do it anymore. Hyperosmotic therapy, okay, we do 3% normal saline or hypertonic saline. Okay, sodium chloride. Then we do this as a bolus first. Normally it's 250. These are the people who we don't have surgery available. We don't have the ability to do an ICP. Like, what can we do in order to decrease the brain edema? And the only thing we can do is try to shift that sodium and give a huge amount of sodium and try to force that fluid out of the brain. Okay, force the blood vessels in the brain to constrict, because the body has gotten a huge sodium load, and so it's supposed to decrease the edema in the brain. Same thing with mannitol. We normally do 3% first to try to reverse the acute effects of herniation until we can get them to surgery. But if we don't have 3%, mannitol is a great one to use, okay? Mannitol though, if you use it, you can only really do it twice, and then you really can't do it again. And as soon as you use mannitol, 3% is never going to really work. So try your 3% first, and then if that doesn't work, then you can use mannitol as the last resort. Judicious fluid management, okay, sedation. We haven't really talked about what RAS means, but basically it is like how awake are they on sedation, okay? Basically we want them at, if they're just a normal sick person and they're intubated, we want them at a -1. Okay, we want them not like, we want them arousable, but by touch. Okay, they just open their eyes, it's very peaceful, they're very calm. -2 or less. Okay, the most RAS you can have is a -5. That is a deep coma. So as long as they're -2, it takes them a bit to wake up. Or we can't. They're really comatose. Okay. The more that they're sedated, the more the brain can rest. The more there is no of the outside activity causing them to be agitated or in pain or whatever it is. Okay, so we really want them in a deep coma. Fever management. Neurostorming is a big thing that we have to deal with. Okay, the brain normally when it's had this big of a shock kind of goes into a freaked out type of kind of status. Okay, and so they may fever without having any signs of infection. It's just they may be tachycardic for no reason. Okay, it's normally between 110 and 120. They may be fevering, but again, all of their chest X-rays, all of their blood cultures, their CSF cultures, there's no sign of infection, but they're still fevering. It is this neurostorming because the brain is on this weird kind of status where they just don't really know what to do. So we may need cooling blankets. Okay, any anti-epileptic, okay, Keppra or let's say this word. Latrucicium, sure. I call it Keppra. I apologize. We can give that IV, all right? We can give Dilantin, Phosphatirin. Basically, anybody who has a bad enough head injury, they're high risk of having a seizure within the first 7 days. So we will put them on we'll do a bolus, okay, a loading dose of an anti-epileptic, and then they'll get a daily dose or twice-a-day dose or 2 times a day dose of some sort of, whichever one we choose, either Keppra or Phos, to prevent those seizures. Sometimes if the head injury is bad enough, we will go beyond those 7 days. Okay, but normally, for a normal mild head trauma that we're worried about seizures, normally we only have to do it up to 7 days. Okay, glucosteroids, we only do steroids in very specific cases. It's normally not recommended anymore unless you're doing it for very specific, and I don't necessarily need you guys to know those specifics. Okay, just know that we don't really use them. Barbiturates. So barbiturates is a different type of medication that we can put them in. Say that we can't necessarily give them a lot of like propofol or fentanyl because it's really causing them to be hypotensive. Okay, we can give them a barbiturate, and actually this is a medically induced coma that has nothing to do with like narcotics or benzos or anything like that. Okay. This is for the worst of the worst head injuries. Okay, we want them in the deepest medical coma to let their brain rest. Therapeutic hypothermia. Okay, you see this a lot with ACS or ACLS. Okay, post MIs, post STEMIs. We also do this for post head injuries. Okay, if we can cool them and do a therapeutic hypothermia. We're not making them too cold, just a little cold. It really can sometimes preserve that brain function while it heals. Okay, and then decompressive craniotomy. Okay, we put the skull plate back on. Craniotomy, craniotomy. You leave it off and let that swelling, and then after 3 to 6 months, you can go back and put the skull plate back on. Or they put a face plate, titanium or steel plastic. Okay, but that is really up to neurosurgery as to whether or not they're going to do a decompressive craniotomy or craniotomy. All right, so you have a 68-year-old. Hit the head, Glasgow Coma scale 12. Pupils are equal, reactive. Hemodynamics are stable. 1 hour later, blood pressure is 190. Right pupil is larger than the left. His GCS drops 8. Which of the following is the most likely performed following the secondary survey? Are you gonna? So this is something that I did change on my other slide deck. Are you gonna wait after the secondary survey to intubate?
Who?
No, you're going to do that during the breathing section, right? Or even the airway section. So I did change this on my slide deck. I'm going to try to find it. I don't think it's saved. So if you guys don't have it, that makes me sad. So yeah, so we're not necessarily waiting for the secondary survey, right? So if this was truly after the secondary survey, you would expect them to already be intubated, right? Then what's your next step? What are you going to do? Blood pressure control shoe? Out of these things?
Oh, out of these.
You might do mannitol, you know, or go ahead and get a head CT. Go get a head CT so we can figure out what's actually going on. Okay. Fair. Good. But given that his pupil is already bigger than his left and his GCS is now 8 with a super high blood pressure, we're probably going to do mannitol on the way to CT scanner. Or at least 3% on the way to CT scanner. Okay. Again, when I write the actual test questions, it'll be way more straightforward than that. All right. What time is it? Take a 10-minute break.
Real quick. Would you recommend a certain movie IMAX or
Yeah.
Dude, does it matter?
Yeah.
We went to a really nice theater and it was the Draft House.
So we make the decision.
They're apparently closing.
They're at Daily Club.
I think we went to,
They're at Daily Club.
they're here, I think
Oh.
They've been in Daily Club?
Where they're going.
No.
I've seen it. I've never been allowed there. Is that for like seniors?
That we may go to CT.
I mean, I can't now.
Yeah, we've had people, their retirement there, but they have a huge venue.
Oh, for graduation. So I thought you were talking about. We're talking about something else. That's why I got confused.
But they had a movie.
So sometimes
Gateway Club is cool.
Yeah, they have this thing.
Yeah, that'd be great.
I think they're closed right now.
Of course.
versus they come in.
You open it for
and
2
even if
hours.
they go 30 feet, they have
I've never been in there.
Nope. Totally fine.
They have a pretty big venue.
And then, you know, then
I
it's
think it works.
You gotta
just
be
public,
plastic
it's
jumper,
straight,
like a PC.
fast, if it's negative,
Oh, yeah.
don't make watching for
Definitely.
more.
I just, as long as we're not charging the chairs, I'm
There
happy.
are cases.
Yeah.
We're gonna have to sit on our chairs. We're gonna have to get a detail.
So it really depends.
So that one's like, you didn't have.
Yeah, the only other bet I could have is if Clipper reserved April 24th.
Right,
those
right.
be a
So if you-
favor.
if you
I don't
look
know
at-
what the squadron was.
So,
Special warfare.
when I was in, the
The-
follow-up
the-
question is,
the best poll I have is
you
like
actually now
people
are
who
following the
don't
secondary
have
survey, so you've done the primary
There's
and
a,
secondary now. What's the next
Way to
step?
cover the swing.
Okay, imagine that if you're in the secondary survey, you're already intubated.
Giant space.
Okay, and now you have a secondary, after secondary survey, his GCS is 8, and he now has.
I'd be concerned about that amount
We
of
want to
people
do
screaming.
something. So he's not normal, he's not,
It'd be cool.
he's
That
not
place is
used to
huge. Like it's
Yeah.
right, he
They have,
definitely
like,
has.
You guys have Infinity money.
You know,
multiple.
something going on, and so we want
Oh,
to
they
get
spent like
about 3%.
an insane amount of money too. Like just to be.
Okay, we're almost done. Bring it back to me.
Save someone's life.
Come on. Now they have like 20 more slides left to go. Let's like just try to, get through this. We can look down. All right. So, going back to, blood pressure management, this is a little, so the rest of the slides are pretty much that one slide but more in depth, okay? Trying to, go more, explain more, okay? So, when we're talking about blood pressure control, like I said, we want that goal between 90 and 100, or 110, okay? This means keeping the MAP above 70 is great, okay? Especially if we think the ICP can be below 20. Most of the time, a MAP of like 65 or greater is still acceptable, okay? And we really want to manage that shock very aggressively with phenylephrine, epinephrine, norepinephrine, okay? It really just depends on, I've seen people on every single blood pressure management known to man to try to keep their shock under control, and sometimes it just doesn't work, okay? But we definitely want to aggressively treat their shock to try to get their blood pressure up. In terms of fluid resuscitation, we normally use normal saline. We do not use LR or plasma-like, okay? Normal saline is what we use for head injuries. Okay? So if there's a question, what's the fluid type of choice with head injuries? It's NS. Okay? You want normal saline. You do not want LR. Okay. Because we want that little bit of sodium to try to decrease that ICP. Okay? Normally the goal, occasionally the neurosurgeons will say, oh, normal sodium is fine. But most of the time they'll want a little bit of a bump increase between 140 and 150, or 145 and 155. What's normal sodium goals? I heard it. 135 to 145. Okay? So we want this above like 10 points more. Okay? And that has been shown to really decrease the amount of cerebral edema. Okay? And then in terms of like, have gravity be our friend. Fluid likes to move away from, the highest point. And so we can put their head up a little bit and try to help, again, decrease that edema in their head. Okay? Like I said before, hypertonic saline, we're always going to use first. The range of concentration, you have to be very, very careful. Normally what we deploy with is 3%, but in hospitals it can go all the way up to 23.4%, which is insanely salty. Okay, so 3% is what we want. Normally we do a 250 bolus over like 10 minutes or something. It really just depends on how much we want to give. We try not to give these through a peripheral IV catheter. These normally are, because of the concentration of sodium and chloride, we want to give it through a central line, through a Cordis or, hopefully they don't have a triple lumen, but if that's the only thing we have, that's what we'll give. Okay, it has to really be through a central line. Mannitol, again, safe for last resort. Normally it's 0.25 to 0.5 grams per kilogram, so it is by weight, okay, over 10 to 15 minutes. Onset of action is really, really quick. Duration can really vary between 4 hours to 24 hours, which again is why we can't really use anything after mannitol, because you don't want to wait 24 hours or 4 hours and say, oh shit, nothing's working, and then give a 3% bolus, and then you're doubling the action and going way above 155 for sodium. Okay. And then again, we want to avoid in those hypotensive patients. Okay. Hypertonic saline is preferred. All right. For agitation, okay, we want a rapid sequence intubation for anybody with a GCS of 8 or less. Normally we use propofol and fentanyl. We avoid succinylcholine. Avoid succinylcholine in head injuries. We can still use it if it's the only thing we have, but we really have to be careful because it can increase the ICP. Aggressively treat the fever. Seizure prophylaxis, we've already kind of talked about this. The Keppra, for 7 days. Okay, if it's a severe, we'll do IV Keppra or fosphenytoin. Again, glucocorticoids no longer recommended. Barbiturates, I've only seen, I think I've seen barbiturate comas a couple times, only a handful of times, for really, really bad, long, long-term head injuries. Okay, they had massive head trauma, and it took them a long time for their brain to kind of get back to normal. I think the one I'm thinking of is their head got smushed between some heavy machinery, and so they had fractures everywhere. Basically, their whole cranium was one big fracture. And so we put them into a barbiturate coma because their brain needed that rest. And then again, last resort is that decompressive cranium. Okay, you have a 65-year-old male, history of depression, schizophrenia, being admitted for craniectomy due to firearms injury to the head. On physical exam, he has a heart rate of 98, blood pressure of 128 over 84, no signs of raised intracranial pressure on fundoscopy. Which of the following is the most common complication for this patient following his traumatic brain injury? What do we try to prevent against?
Seizures.
Seizures. Alright, absolutely. What's his second most common on this list?
B.
Meningitis, right? So he had a foreign body missile through his skull. Okay, so we want to protect against seizures. Alright, hyponatremia really promotes further brain injury. Okay, and it can lower that seizure threshold. Okay, so we want, there's two main brain injury patterns that we see. So cerebral salt wasting and syndrome of inappropriate antidiuretic or SIADH. Okay. So we look for these when we have patients who have brain injuries. We watch them. This is normally about it's not going to be an initial presentation. This is, post-op or post-day, maybe 5, maybe 2 weeks out. 1 week to 2 weeks out. Okay, it really just depends on how bad their injury is. But they will have just like normal urine output, and then all of a sudden they start dumping urine. Okay. Your urine osmolality and urine-specific gravity are super important, and we will measure these almost hourly, just to see when we need to actually give DDAVP in order to try to reverse the SIADH. Okay. Or the DI. Cerebral salt wasting really has to do with that release of brain BNP. Okay. The biggest thing is we want them to be euvolemic. So anything that they pee out, we try to give back, and we try to fix their underlying cause, either giving them sodium or the DDAVP if we need to. Okay. This is a great chart to try to go through and see what type of treatment do we need to do. Is it cerebral salt wasting? Is it DI? Or is it SAIDH? Okay. I'll let you guys kind of look through that. The biggest thing is, when you have that massive urine output, it's really going to be either cerebral salt wasting or DI. You're actually going to have a decrease in urine with SAIDH. Sorry. All right. Removing of the CSF. There's neurosurgical things that neurosurgery will do is, like I said, that ventriculostomy, putting that drain actually inside of the ventricle into intraperitoneal bolts, decompressive craniectomies, craniotomies, and then that barbiturate metabolic comas. Okay. Really what we do is, we have something that just needs to be monitored. We'll do a bolt. If it's something that we know that we're going to have to try to take fluid off or use, the CSF as a way to try to, manage the pressure within the head, then we'll use an EVD or the ventriculostomy. It really just depends, but our goal is to keep the ICP less than 20. All right. So, when you have braced head herniation, what is it going to present like? Okay, they're going to be altered. They're going to have headaches. they may be vomiting, they may have that papilledema. And you'll learn this, I think your next block of EM is your ultrasound. You'll learn how to do ultrasounds of the eye in order to actually look at the optic disc or optic nerve, okay, and actually measure the nerve and actually see if you have papilledema or not. Okay, it's really cool. You'll learn to do that as well. So when you have Cushing's triad, okay, you have elevated systolic blood pressures, bradycardia, and you have that irregular respiratory pattern. That's Cushing's triad. Okay, there's a very late sign of increased ICP. You really want to try to catch it before this, because most of the time, once you have those three things, herniation has either imminently going to happen or it's already happened. Okay, ungual herniation is herniation through the tentorium, so coming down into where the cerebellum is. Okay, and then when you have tonsillar herniation, it is through the magnum or foramen magnum. Okay, it's where the cerebellum actually comes down through the base of the skull. Okay, so with ungual herniation, you're going to have contralateral hemiparalysis, so the opposite side is going to be weak. You're going to be diminished consciousness, and then again, that ipsilateral, same side type of pupillary changes. Okay, and then they may have a lateral gaze as well. And then with that tonsillar herniation, you're just going to have respiratory depression and death. Okay, once you have tonsillar herniation, it's really hard to because what is right next to the foramen magnum? What's your brain major function is there? What's your major anatomy that's in the foramen magnum? Or right above it? Pons, right? That's your respiratory center. Okay, that's your midbrain. Okay, if that gets squeezed down into a tiny little hole, yeah, you stop breathing. Okay, you die. It's very hard to come back from that, if you can. Okay, so when you're unresponsive with a GCS of 3 to 5, okay, really you should start thinking of brain herniation. All right, you have a 60-year-old woman rushed to the emergency department after being an unrestrained driver in a motor vehicle crash. Your GCS score at the scene is 4. She's intubated for airway protection. Which of the following physical exam findings is most concerning for severe increased intracranial pressure?
Delta?
Who wants alpha? Who wants bravo? Charlie, delta, echo.
Let's go home.
Bradycardia, absolutely. Good job. All right. What do we do to treat it? Okay. Now, you want to elevate the head of the bed if you can. Normally keeping the bed straight. Okay, just elevating the head, lowering the feet. Okay, you want a definitive airway. If all you have is a supraglottic airway of LMA, fine, but you really should have it endotracheal intubation. You have to get past those cords for definitive airway, or else it may not work. Okay, adequate ventilation. Okay, now this is where I start to talk about the hyperventilation stuff. Okay, when we talk about this over the next couple slides, this is not at your level 1 trauma centers. This is not at your role 4, you know, military treatment centers across the world, right? This is your BAS, your little basic aid station, okay? You don't have a neurosurgeon, you don't have mannitol, you don't have 3%. Like, this is your no shit, what can I do for a temporary time frame? Okay, you do this for a very, very short amount of time to try to mitigate the success of them actually making it to that next stage of treatment. Okay, hyperventilation is something that you can do on a very, very, very short time frame in order to try to decrease that ICP very, very quickly. It is not sustainable. Remember, it will eventually increase the ICP. This is not something you do every day in a normal hospital. You are in BFE, like you have no one to help you. and you are just trying to save their life in order, like, get them just long enough until you have someone like medevac or whatever, get to you in order to save them, okay? So we increase their, we intubate them, we put them on capnography, okay? Really, you should not be trying to even try to attempt this without capnography or the ETCO2. Okay, you must have very strict parameters in terms of what you want that CO2 to actually do. Okay, normal is between 35 and 45. So when we go down to 25 to 35, that's hyperventilation. You are really bagging them quickly in order to try to blow off that CO2. Okay. And so, again, you do this for a very, very short amount of time. Your NCO2 is between 25 and 35. And this gives the brain a little bit more time to swallow, but again, eventually it will lead to, increased ICP and ischemia. So you don't want to do this for long, okay? Temporary measure. This is just to off-gas that CO2 to try to give you a few more minutes until that medevac gets there. If you're doing, like I said, capnography is the monitor that you want to do, that ETCO2. You really don't want to do yellow or the colorimeter. Okay, you can, but again, I would not recommend it. You really, to do this successfully, really should have end-tidal CO2, or you really shouldn't be even attempting it. Okay? Again, so you want to do it between 25 and 35 for a very short amount of time in order to make it work. Alright, following a motor vehicle accident, 35-year-old male is agitated and has multiple cerebral contusions on the CT. Hemodynamically measurements, heart rate of 85, MAP of 84, ICP of 28. What's the most appropriate management regimen over the next few days? What do you want to do?
Okay.
What's the most likely thing you'll do? Alpha, right? Okay. You don't know what their MAP is, or you don't know what their blood pressure is, right? But with a MAP of 84, you probably suggest that it's low, but I don't know that I would do phenylephrine to increase the MAP. MAP of 84 is pretty high already, right? You want it above 70. So you want to do something to decrease that ICP. And so mannitol is the thing. Over hyperventilation, again, you're not going to do over a few days. And Trendelenburg is feet upward. It's the wrong way. You want feet downward. So reverse Trendelenburg.
Why not have hypertonic saline as an option
Because my slides didn't save, man.
though?
I tried and it didn't save. I even tried looking through my computer and it didn't save, so I apologize. If it was hypertonic saline, you would do hypertonic saline. But since mannitol is an option, we're doing mannitol. Does that make sense?
Oh.
Cool. Alright, so TBI overview. A primary survey, project against that airway, try to manage that airway, get definitive airway, prevent hypoxia, prevent hypotension. Okay, you want that blood pressure above 90 to 110. Aggressively treat hypotension. Okay. Prevent hypoglycemia, manage that ICP, right? You want to keep that ICP less than 20. If that MAP is already super high, you have to do something in order to get that ICP down, which would be either 3% mannitol or doing some sort of thing to the brain in order to allow for swelling. Okay. Now, if your MAP is super low and your ICP is high, then you want to give a shit ton of vasopressors to get that blood pressure up, fluid to get that up, or mannitol, anything that we can do in order to get that blood pressure up. Okay. All right, patient has blood head trauma on presentation, Glasgow scomus pills, 13 is hemodynamically stable. Pupils are equal and reactive 2 hours later. His left pupil is larger, his blood pressure is now 180, tachypnic, and SpO2 of 89 on 100% oxygen. Which of the following is the most appropriate next step in managing this patient?
I do A and C.
What do you want to do?
A.
Who wants to do alpha? Who wants to do bravo? Couple bravos. Charlies. Deltas. Okay. For those of you who said CT, are you going to send somebody with a super high blood pressure, a blown pupil, and an SpO2 of 89 without giving a definitive airway? Because it don't. Yeah, 100%. Just it's not intubated at 100%, right? It's just not a rebreather on 100%. Or just assume that they're not intubated. So you want to do intubate, mannitol, and then an urgent PET CT. Okay? So, but the thing you do first is intubate. Have protective airway. They now are GCS of 8. They have a blown pupil, and they're all. All right. Thanks, guys.